guys, welcome back to Codemaster Coach, your medical coding tutor. As promised on my previous video on UHDDS, Uniform Hospital Discharge Data Set, I said in this next video I will be talking about principal diagnoses. If you don't learn anything under this UHDDS series of videos, make sure you understand what a principal diagnosis is. A principal diagnosis is that diagnosis which after study was found to have occasioned the patient in the hospital. That's the book definition. Layman's terms, you might go in with a headache, high blood pressure, nauseated, all kinds of symptoms that are wrong with you, but after study, after they run your lab work, after they've done your x-rays, after they've done all the tests on you, when they ultimately figure out what's wrong with you, that's your principal diagnosis. You need to be able to read a medical record and determine, based on what your physician has documented, what your principal diagnosis is. Okay? If you don't write down anything else from this video, make sure you write down the definition of principal diagnoses. And again, it's the condition established after study to have been chiefly responsible for occasioning the admission of the patient to the hospital. Put it in your own words so that it makes sense to you. But it is important that the principal diagnoses be designated correctly because it's significant for cost comparison, care analysis, and utilization review. In other words, as far as statistics for your hospital goes, your signs, your headache, your high blood pressure, your nausea and vomiting, after they've run the tests and they've determined that, yes, you do have an aneurysm or whatever could be wrong with you, that one diagnosis, all of your care, your financial, your third-party payer payment, your insurance company payment is going to be based on that principal diagnosis. So it's real important that you, out of all the information that's given, that your physician designated. Now that's on an inpatient basis. Again, it says it's crucial for reimbursement because many third-party payers base their reimbursement primarily on that principal diagnosis. I always compare it to buy one at full price and get your others at a fourth of the price or half price. Well, that's kind of how diagnoses work. Your principal diagnoses should be reimbursed at the 100%. Even though insurance pays 80% of the 100, that 100% is based on that principal diagnoses. And then your other diagnoses, your comorbidities. Comorbidities are conditions that you have along the way. Like a lot of times, patients walk around with high blood pressure every day. But when they're admitted to the hospital for a particular condition, and I was using the example of a brain aneurysm with the headache, and well, even though they've got that brain aneurysm, they still got hypertension. You still have to take your high blood pressure medication. They still have to monitor your blood pressure. So that's considered a comorbidity. That's an additional condition that's wrong with your patient that still has to be taken care of. But your ultimate reimbursement is going to be determined based on your principal diagnoses. So the key to knowing what a principal diagnosis is that condition after study. Okay? That was found to have occasioned the patient to the hospital. Let me give you a couple of examples that you'd need to be aware of. A patient's admitted with urinary retention. They're unable to pee. They got that pressure in their bladder. They need to go to the bathroom. They need to pee, but they can't get it out. And they may prove to have hypertrophy of the prostate. So we know this is a male patient, right? Which is causing the urinary retention. So in this case, the prostatic hypertrophy is your principal diagnosis unless your physician treats it just the urinary retention. So in that case, principal diagnosis is benign prostatic hypertrophy. Give you another example. A patient may be admitted because of unstable angina. And remember what unstable angina is? That pain that radiates down the left arm. And a percutaneous transluminal angioplasty. A procedure may be carried out to clear that arteriosclerotic blockage of the coronary artery. And what their goal is to abort an impending myocardial infarction, a heart attack. So in this case, the coronary arteriosclerosis is the principal diagnosis, because after study, it was determined that the underlying cause for the angina was the arteriosclerotic blockage. So that becomes your principal diagnosis. So we kind of getting what I'm saying here? Another example, patients admitted with severe abdominal pain. White blood count is elevated. The patient is taken to surgery where an acute ruptured appendicitis is removed. So after study, remember they came in with the abdominal pain, elevated white blood cell count. So after study, it was found that they did have an acutely ruptured appendix, and that was removed. So appendicitis becomes your principal diagnosis. That which after study, after the surgery, it was determined that that ruptured appendix was the cause of the abdominal pain and the elevated white blood cell count. One more example, a patient admitted with severe abdominal pain in the right lower quadrant, and an admitting diagnosis of probably an acute appendicitis is given. Now notice that's the admitting diagnosis, not principal. Because admitting, and remember the difference with admitting and principal is, on admission, you go to the emergency room with your headache. That's your admitting. But after study, it was found. So in this case, patients admitted with severe abdominal pain in the right lower quadrant, and an admitting diagnosis is probably an acute appendicitis. The white blood cell count is elevated, as in the previous case. So the patient is taken to the surgery, and they find a normal appendix, but they find an inflamed Meckel's diverticulum. Part of their intestine was inflamed, and that's removed. So after study, the principal diagnosis in this case is the Meckel's diverticulum, because the appendix was fine. They removed the appendix, but it was fine. It was not inflamed. It was not ruptured. What had happened was that Meckel's diverticulum ended up being the problem. So again, you've got to look at what occurred after study, and that becomes your principal diagnosis, and that's your first listed diagnosis on an inpatient claim. Okay? Now we do have unusual circumstances. Remember we talked about observation. When you're admitted to the hospital, you're not fully admitted. They're just going to observe you for 24 to 48 hours to determine whether or not you justify staying in the hospital. A lot of times, when you come into the ER and the physician sees you, he doesn't want to send you home because you might live alone, or they know you're right on the verge of something happening, but they're not really sure, and so a lot of times they'll keep you in the hospital and observe you, and insurance companies will allow that for up to 48 hours. The goal is to bring you in and monitor you for 24 hours so that whatever is going to occur will hopefully occur within that 24 hours to determine whether or not you need to be admitted, fully admitted to the hospital. And I always tell my students, an observation, you're put in a hospital bed and they monitor you by machines at the nursing desk. Whereas when you're an inpatient patient, you're in the hospital, someone's in there every hour on the hour, they don't let more than 4 hours go by, and they're coming in checking on you. But observation, you don't need that critical nursing care continuously at your bedside every hour on the hour. They tend to just monitor you from machines at the nursing station. But what happens if you're admitted after being observed? So I'll give you an example here. A patient is being treated in a hospital observation unit to determine whether the condition improves sufficiently for the patient to be discharged. If the condition either worsens or does not improve, the physician may decide to admit the patient for an inpatient stay. So the principal diagnosis reported is that medical condition that led to the admission. All right, what about admission following post-operative observation? So a lot of times when you come in and you have your same-day surgery, a lot of times they'll observe you for 3 to 4 hours after your surgery to make sure your blood levels, your levels come down to a point where you can go on home. Well, what happens, or what diagnoses do I use if after surgery, you started having tachycardia. Your heart started beating a little too fast, or your blood pressure jumps up. Well, we had brought you in for same-day surgery that you're supposed to go home with. But then all of a sudden you started having tachycardia or increased blood pressure. So after study, if the patient subsequently requires that inpatient admission, then the definition becomes that condition established after study to chiefly be responsible for admitting the patient to the hospital. So that surgery didn't justify admitting you. It's that other condition that happened, that tachycardia, rapid heartbeat, or the increased blood pressure. That becomes your principal diagnoses. Okay, we're feeling my vibe now. We're realizing what's going on with principal diagnoses. Let me give you another one. Outpatient surgery again. You could be admitted inpatient hospital care, and it's based on the following guidelines. If the reason for the inpatient admission is a complication, then you assign that complication as your principal diagnosis. But if no complication or other condition is documented as the reason for your inpatient stay, then you assign the reason for your outpatient surgery as your principal diagnosis, because something still does not have you right to go home. Your heartbeat didn't increase, your blood pressure didn't increase, but yet for some reason you're just not ready to go home and they feel like they need to admit you, then your surgery condition justifies admission to the hospital, and that becomes your principal diagnoses. And if the reason for the inpatient admission is another condition unrelated to surgery, come in and you fall and break your leg, that doesn't justify inpatient stay. You come in and something else goes wrong that justifies an inpatient admission, then that condition becomes your principal diagnoses. Okay? All right. Now, there are instances where two or more diagnoses equally meet the definition. And I've seen that, where a patient will come in and they actually have two things wrong with them at the same time. How do I know which diagnoses to list first? Because remember, Coach said, whichever one you list first, it's going to be the one that your insurance company is going to reimburse you on. So you want to make sure that you list the first one or the correct one first. So then how do you know which one to list first? Let me give you an example. And the key here is when treatment is totally or primarily directed toward only one of those conditions, or if only one of those conditions justifies inpatient stay, then that condition becomes your principal diagnoses. All right, let me give you an example. Patients admitted with unstable angina, okay, and acute congestive heart failure. The unstable angina is treated with nitrates and intravenous Lasix, a medication through IV, and given to manage the heart, Okay, I said that too fast. With the unstable angina, nitrates are given. And with the congestive heart failure, intravenous Lasix is given. So here you've got two conditions and both were treated. Both diagnoses meet the definition of principal diagnosis equally. So either one can be sequenced first. And what I found a lot of times with the cases like this is they both carry the same weight, which is something we'll get into on a later video. But diagnoses are weighted. They're given a weight, and based on that weight, reimbursement is rendered. So a lot of times conditions will be in the same weight category when they contrast each other like that. Okay? Patients admitted with severe abdominal pain, nausea and vomiting, and is due to either acute pyelonephritis or diverticulitis. Acute pyelonephritis or diverticulitis. Both underlying conditions are treated, and the physician believes both equally meet the definition of principal diagnoses. So in this case, either one of those can be listed as the principal diagnoses. Okay? Two or more comparable or contrasting. Now, it could be equal or they could be direct opposites of each other. So in that case, it says here, the patient is admitted with severe abdominal pain, nausea and vomiting, and again it's due to either acute pyelonephritis or diverticulitis. The patient is treated symptomatically and discharged for further studies. Now, when a patient is treated symptomatically, that means when the doctor walks in the room, oh, today you have a headache, we're going to go ahead and give you some medicine for the headache. We're going to try to figure out what's causing those symptoms. We're going to just take care of those symptoms. But he knows it could either be acute pyelonephritis or diverticulitis. So in this case, both conditions meet the criteria for principal diagnosis equally, and either one can be listed as your principal diagnoses. Treatment of another patient. Same symptoms, nausea, vomiting, abdominal pain, and it can be either pyelonephritis or diverticulitis. Well, in that case, if your physician directs most of his attention one way, toward either the acute pyelonephritis or the diverticulitis, whichever way the physician leans, you lean with your coding, and that's your principal diagnoses, okay? So in that case, the physician feels that that condition actually led to the admission to the hospital. Both conditions are coded, but whichever way the physician leaned, that diagnosis is listed first, okay? And then sometimes you have a symptom, and then it's followed by a comparative contrasting diagnosis. Okay? And that example here is a patient's admitted for workup because of severe fatigue. The discharge diagnosis is recorded as fatigue. That's all your physician lists, fatigue. But then he says it's fatigue that's due to either depressive reaction or hypothyroidism. So in this case, your symptom code, fatigue, is designated as your principal diagnosis because that's what your physician said led to the admission of the patient to the hospital. And then you assign additional codes for both the depressive reaction and the hypothyroidism. Because it's either, he said that fatigue is due to either that depression or that hypothyroidism. So evidently the patient has both of those conditions, but the doctor just didn't know which one is causing the fatigue, but the patient does have both. Code your fatigue as your principal diagnoses. And one more example of that. Your discharge diagnosis is stated as gastrointestinal bleeding. And it's due to either acute gastritis or angiodysplasia. In this case, the diagnosis coded is comparative and contrasting, and there's no separate code assigned for the bleeding because both acute gastritis and the angiodysplasia would have the gastrointestinal bleeding. And so you code both conditions, and either one could be coded first. Okay? In the previous one, fatigue brought him in. In the second case, gastrointestinal bleeding, but the two diagnoses that the patient had, gastrointestinal bleeding is a result of either. In other words, you'd be double coding if you coded gastrointestinal bleeding, acute gastritis. Acute gastritis does have gastrointestinal bleeding. But in the previous case with fatigue and then the depressive condition, depressive reaction and hypothyroidism, not all patients with hypothyroidism and depressive reaction have fatigue, but this particular patient did. And that's why in that case, you code fatigue and then you code acute depressive reaction and hypothyroidism. But in the second case, with the gastrointestinal bleeding, if you have acute gastritis, it's inflamed, it's bleeding. If you have angiodysplasia, it's inflamed, you're bleeding. So in that case, rather than code that symptom code with the two comparative contrasting diagnoses, you just code the two comparative contrasting diagnoses. Okay? Now, what about those times when the original treatment plan is not carried out? You know, those times when a patient, say for example with benign hypertrophy, is brought in for the purpose of a transurethral prostate resection. They're brought in to have surgery to remove that blockage. Shortly after admission, but before the patient is taken to the operating suite, the patient falls and fractures their hip. So then you have to cancel the previous surgery and then instead take the patient to the OR to pin the hip because of the fracture. So in this case, the principal diagnosis remains hypertrophy of the prostate because that's what they were brought in for originally, but then the procedure will change. So in a case like that, it's going to flag. Your third party payer, your insurance company is going to say, wait a minute, you brought him in for benign prostatic hypertrophy and you pinned the hip. Well, the reason for the admission is still benign prostatic hypertrophy, but I'd also code fractured hip, and then my procedure would be pinning of that hip because that's what happened on this admission. Another example, a patient with a diagnosis of carcinoma of the breast, and it was confirmed with an outpatient biopsy, is admitted for the purpose of a radical mastectomy. They're going to have that breast removed. Well, before the preoperative medications are administered the next morning, the patient indicated that she's changed her mind and has decided to seek other treatment instead of having the surgery. So no treatment is given to this patient. She's discharged home. The carcinoma of the breast is still the principal diagnosis because that was the reason that she was brought in. No treatment was rendered, and so that still remains your principal diagnosis. So hopefully, guys, I've broken down principal diagnoses enough so that it makes sense as you're reading medical records and you're trying to determine what do you list first, because as we get a little further in our coding, you're going to need to understand how to list your codes as we're coding them. So your first listed code, and this is for inpatient as far as that which after study. Now in the next video, we're going to be talking about other diagnoses and what other diagnoses you code. But for the principal, which is your first listed diagnosis, which is going to carry the weight of that admission, you need to make sure that you get that condition correct because that's where your money is. The next video, again, as I said, we'll be talking about other diagnoses, admitting diagnoses. I'm also going to talk about procedures, and I'm going to talk about the difference between inpatient principal diagnoses and outpatient, because again, there is a difference. You don't have all those studies on an outpatient basis to lead to a definitive diagnosis. On outpatient, you're going to the doctor's office, your head hurts, you've got a headache. They haven't run all those tests that they did on the inpatient. Therefore, you don't have an after study. So we're going to talk about outpatient coding. We're going to talk about long-term coding, and then the ethics of coding. All of this comes within the UHDDS guidelines for statistical purposes. All right, guys, hang in there. We're going to do this. Any questions, leave them below or email me at codemastercoach@gmail.com. Enjoy the ride.